Hi everybody, today we'll be discussing technique of double contrast barium enema. Normally the patient will be in left lateral decubitus position. This is for the preparation for placement of the rectal tube. Before placing the tube, inspect the anus for large varices, inflammatory bowel disease, carcinoma and sinus tracts. Lubricant is applied at the tip of the enema tube to reduce the pain in hemorrhoids, inflammatory conditions. So first the patient will be in left lateral decubitus position. So you put the rectal tube. Then distal rectal examination to access the sphincter tone to determine whether the balloon catheter inflation is needed to retain the rectal tube. So you do a distal rectal examination to see the sphincter tone, so that whether the balloon catheter inflation is needed or not. Any hemorrhoids, masses, inflammatory condition assessed during distal rectal examination as inflation of the retention balloon risks the rectal tear, aberration and increases the risk of hemorrhoidal bleeding. Before putting distal examination, you see the conditions like hemorrhoids, you see the conditions like inflammatory bowel disease. It's because inflation of in these conditions we should be very careful, because inflation of the rectal retention balloon, it causes rectal tear, aberrations, increased risk of hemorrhoidal bleeding. Patients who have an history of pelvic irradiation, rectal ulcer, distal rectal mass, suspected rectovaginal fistulas, previous anal surgery may not be suitable for balloon catheter inflation. So before doing a balloon catheter inflation, make sure that you should have an history. If they have an history of pelvic irradiation, if they have an history of rectal ulcer, distal rectal masses, suspected rectovaginal fistulas or previous anal surgeries, they are not suitable for balloon catheter inflation. So first what happens, you take a scout view. In the scout view, we take a AP abdomen, anteroposterior pelvis and left lateral pelvic view. The scout view, you take 3 views. Then the patient is in prone position. Barium is slowly administered until it reaches the mid-transverse colon. Then after it reaches this point, drain the barium from distal rectosigmoid and rectum. Begin manual gas insufflation. So for the once the barium goes, the patient will be in different positions for the barium to reach. For example, in left lateral decubitus, head down position, it is used to fill the descending colon. Prone position to fill the transverse colon. Right lateral decubitus to fill the hepatic flexure. Supine feet down to fill the ascending colon. Then drain barium by appropriate position using gravity and tube. Then we have to inflate the bowel by compressing the upright back, apply steady pressure and allow time for air to pass around the bowel. Okay, these are the positions in which the barium will be going. You have to keep the patient in that position. Then these are all the views. For sigmoid colon we take LPO, RPO and prone position. For rectum we take prone lateral. For hepatic flexure we take erect LPO. Mid-transverse colon we take erect or supine. Splenic flexure we take erect RPO. Proximal descending colon we take erect RPO. Cecum we take LPO and prone. Rectum tip out supine or right lateral. Thermal ileum LPO if there is any question of inflammatory bowel disease. Supplementary overhead radiographs are also useful. Prone left decubitus, right decubitus, prone cross table lateral of the rectum, prone caudally angle rectosigmoid. Degree of gas inflation. If you do too little gas, it will be difficult to identify the pelvis. If there is more gas, they will cause compression of the flatten the colonic lesions and may cause potential patient discomfort. For any part which is constricting, we have to go, and it can be due to colonic spasms. So we have to come back to the image and see if it has opened up. So this is the technique. Thank you.